coverage. Please welcome to the stage Robert Yates from Chatham House, a political health economist. Where is he? Yep, off you go. Thank you very much.
Thank you. Thank you very much indeed, Tanya. And thank you very much for inviting me to these absolutely fantastic surroundings. I don't think I've ever presented in such a sumptuous situation as this. It's absolutely marvellous. And please, would people take photographs? I'd love to show my children back home in England that be in front of a big stage like this, like a rock star. They'll be ever so proud of their dad. But thank you so much for inviting me to the conference here today. My name is Robert Yates. I call myself a political health economist. I'm not sure if this is a legitimate job title, but as I speak to you today, I hope you will understand where I'm coming from on these messages. That really, universal health coverage is as much about politics as it is about health and economics. And really, if we want what we're going to get out of UHC, we need to be thinking very politically. So, without any further ado, I'd like to talk about how we can ensure that UHC reforms really do benefit cancer control. And as we've been discussing, universal health coverage is dominating the global health agenda at the moment. Just 3 weeks ago, heads of state after head of state was talking about universal health coverage at the UN. We've made the front of The Economist, so we must be important in sort of really addressing a world agenda. And we can see all these other aspects as well, that there's been a UN resolution on universal health coverage. There's now a UN day, the 12th of December, which is celebrating universal health coverage. It's an SDG target. And very interestingly, you're seeing a number of organisations like the World Bank and WHO saying that the way to achieve the overall health SDG, when it comes to the health sector's contribution, will best be done through achieving universal health coverage. So we can't afford to ignore it, and people interested in cancer control really do need to be engaging in these debates. So what is universal health coverage? We haven't really had it defined yet, and I think it is important that we do, because there are misconceptions about what universal health coverage is. Some people associate it with having health insurance coverage, but you can see that's definitely not the case. From this definition, UHC means that all people can use the promotive, preventive, curative, rehabilitative and palliative health services they need of sufficient quality to be effective, while also ensuring the use of these services does not expose the user to financial hardship. So you can see there are basically three parts to this. First of all, the universality, that everyone gets it. Then it's people receiving a full spectrum of health services. We're not just talking about hospital services and curative services, also about promotion and palliative care at the other ends of the spectrum as well. And you can see, those of you interested in cancer control, which I hope that's everyone here, that means all those services there. But there is this vital element as well about people being protected from the financial costs. This is absolutely essential. As Princess Dean has been saying, we can't have people plunged into poverty because they are accessing services. But behind that simple definition, you can very quickly see that this is quite profound, and it's about fairness and equity, and this very much takes you into the realms of rights and politics as well. Because if we're serious about universal health coverage, that means literally everybody on the planet, no one should be left behind. So we're not just talking about citizens, we're talking about refugees and migrants. Everyone on the planet should get it. No one should be left behind. Also, we're recognising that health services should be allocated according to need. It's not the case that everyone gets the same amount of healthcare every year. People, say with cancer, say people at risk of getting cancer, objectively need more healthcare than other people. Pregnant women need more healthcare. Disabled people need more healthcare. So we're not talking about an equal allocation, we're talking about an equitable allocation of health resources. Then there's this issue of the financing. If we are serious about everyone on the planet having financial protection, then logically We're talking about health systems which are paid for according to your ability to pay. Richer people pay more into the health system than poorer people. And so combining those elements, we're really talking about a health system whereby healthy, wealthy members of society cross-subsidise the sick and the poor. Now, it's important to state that UHC isn't just about health financing. You've got to deal with all the health systems, medicines, human resources, information technology, governance. But if you don't get the financing right, you don't stand a chance. And I do want to just dwell a bit on the financing. Because after there being years and years of hot debate around health financing, I think the world is coming to a consensus now around UHC that, quite simply, a market-driven, privately financed health system will never, ever result in universal health coverage. Because you don't get the cross-subsidies. The rich people just won't pay for the poor as much as they ought to. And the one country that really exemplifies that, and apologies to any American friends in the room, is the United States. You know, a system that spends 18% of its GDP on its health system, and yet 10% of the population still don't get coverage. What we're learning is that if we're serious about universal health coverage, there's an enormous role for governments and the state to force the healthy, wealthy to cross-subsidise the sick and the poor. And moving towards that is inherently political. Just talk to friends in the United States or South Africa or many other countries that are making this transition at the moment. And so what you need is the state to be involved in all the functions of the health financing system in terms of how you raise the financing fairly and equitably, with rich people paying more than poor people. Also, the pooling of resources. You know, it's much more efficient to have all these resources in a big pool rather than fragmented in lots of different insurance schemes. And then on the allocation side, once you've got your big pot of public financing, now it might be that the private sector is involved in the administration of these funds, but the state again has a huge role to say which services are going to be covered next, which population groups are going to be covered. We seem to be leaving out palliative care. Why isn't that being covered? Now, so I'm emphasising the role of public financing in achieving universal health coverage. This doesn't necessarily say that the public sector has to run the services. And there are many countries where public financing is used through private sector. For example, France and Japan are very good examples of that. But again, I come to this point that the public financing is key. And that's why I think it was very significant what Dr. Grohal and Brundtland said at the United Nations just 3 weeks ago. She said, if there is one lesson the world has learned, it is that you can only reach UHC through public financing. And so for the journalists in the room, as Tanya was saying, wanting a story, I think that's the story, that you must publicly finance your health system if you want to achieve universal health coverage. Now, that's not to say that, you know, other people can take out supplementary private insurance if they want to, but the bulk of the financing must come from the public sector. And I think this graph sort of illustrates the journeys that countries are making towards universal health coverage. You can see the countries at the bottom right there are those that you associate with a good UHC system. Australia, New Zealand, Japan in particular has got an excellent health system. They have high levels of public spending as a share of GDP, and as a result, they take the financing burden off the population. People aren't having to pay large sums out of pocket to purchase their health care. The countries at the top left, though, are beginning their journeys. They have low levels of public expenditure as a share of GDP, but up to 70, even 80% of expenditure is out of pocket. And we know this is the worst way to finance a health system, because basically only the rich people get the health care and poor people get left behind. So the journey to UHC is really a matter about coming down this curve, increasing public financing to crowd out private financing. And what you find is that countries make big moves down that graph, and it's always led by politicians. A politician saying, as we've been hearing in Kazakhstan, the minister saying the government is committed to doubling public spending and spending 60% of that on primary health care. That's an excellent example I think others should be following. And I mentioned Kazakhstan just last year with the Honourable Minister sort of discussing the importance of primary health care, that if you're going to be publicly financing your health system and putting maybe 1 or 2% of your GDP into your health system, you need to spend that very cost effectively. And you get your best buys in primary health care, and that's true for all diseases, including, as we've been hearing, cancer services as well. So, I've been talking in general now about universal health coverage and what it means. Now, what are the implications for cancer services and oncology? And here I think it's very important to recognise that cancer and cancer control has got a great case. So don't worry. I mean, I think if it were I addressing a sort of a confederation of, say, plastic surgeons, I think people would perhaps be a bit worried that, you know, they don't hit the criteria. But cancer services definitely do. So you're on very, very sort of strong grounds, because it's absolutely obvious that people requiring cancer services, preventive, curative, palliative, are high population groups. I mean, that just goes without saying. And often, because of the costly nature of some of the treatments, you know, they've got a low ability to pay for the services. They need those public funds if they're going to get the services. We also know that many cancer services are extremely cost effective. We've been hearing about this already over the last couple of days. So that combination of them being good value for money, high need, is a top priority for universal coverage. No one should be left behind. And therefore, they really should be predominantly publicly financed. You know, it shouldn't be the case that people are having to voluntarily take out insurance or buy services out of their own pockets. These services should be at the front of the queue to be publicly financed. And I very much want to emphasise how important it is that palliative care services are part of the packages as well. Sadly, often the case, because of the nature of our work and the focus on curative services and hospitals, that end-of-life care is neglected. But, you know, as Dr. Tedros has said himself, it's not universal health coverage without palliative care as well, and that should be a vital part of the package, which I'm sure we all support. So, how are we going to ensure this, though? Because, you know, the evidence is absolutely crystal clear, and I think that we in the health community are masters at restating the problem and talking to ourselves and saying how bad things are, but how are we tactically and strategically going to get the cancer services covered? And these are just some suggestions for us to be considering. First of all, and we heard it in the last panel, the importance of evidence and research. You know, there's going to be competition for resources, so it's vital that we're presenting the best evidence about health outcomes, efficiency, and equity as well. I think it is also very important for the community to come together and recognise that as the world is tracking progress to universal health coverage, people are looking at indicators, and you know, we know from, say, the maternal and child health community that the standard indicators of children immunised, babies born in health units, one feels that we need the same type of indicators for cancer services, so that when countries are being tracked on their overall UHC progress, specific cancer services are identified. And that will be a debate for the community to have as to which ones are the best indicators. But really, I think what we're learning is that advocacy and political action is where you make the difference. I went to a lovely presentation yesterday where Kenji, I'm not sure if he's here, from Mexico, was talking about the cancer crusaders or the cancer advocates from Mexico who were sort of fighting to get the law changed so that parents can take parental leave to look after children with cancer. This is the type of stuff, you know, to take it to the politicians and to present to them that this is what people expect. I would also strongly recommend to stay within the UHC campaign. You know, that I think we're learning the fact that so many heads of state came to the United Nations, understand UHC, that this is a brand that is working with heads of state. They like UHC, they understand it. And if we go every year with sort of different concerns, maybe NTDs, NCDs, AMR, a cocktail of acronyms, we don't look very organised. And I think UHC is the thing that brings us all together. So united we stand, divided we fall, I believe. But in selling the benefits, both of cancer services and UHC, I think we need to be smarter about selling the benefits. I mean, obviously, we're experts at promoting the health benefits, but we need to get better at promoting the economic benefits, particularly to ministries of finance who are going to be paying for it, but thinking about, say, the environmental benefits, you know, say about air pollution and reducing the impact on cancer there. But I think the one area, surprisingly, that we're weakest on is promoting the political benefits of investing in health and cancer services. Really taking it to the politicians and saying, look, if you do this, you will become popular. There are votes in this. You will win power. And I think sometimes we're a bit reticent of just going route one to the head of state, someone fighting an election, and saying, if you do right by cancer control and UHC, you will get elected. And we are seeing this, you know, politicians like cancer services. You know, it's a way for them to demonstrate to the population. This was our former Prime Minister, I think in the run-up to the 2010 election, when he was sort of campaigning to become Prime Minister, saying, let's fund new NHS cancer drugs. And you might just be able to read below, it says, vote Conservative. So you can see the direct pitch there. And you know, this is what politicians like to do. In Pakistan, the new Prime Minister, Imran Khan, very famously has launched big cancer hospitals in 3 Pakistani cities. It's undoubtedly one of the reasons that he's popular. And the fact that he is a sort of a champion of cancer services would automatically make you think that people interested in UHC and cancer control ought to be talking to the Prime Minister in Pakistan, and I'm sure they are. Now, one person who has definitely got it in terms of talking to political leaders is Dr. Tedros, a politician himself, you know, not a medical doctor, but a politician who recognises the importance of talking to heads of state. And he's been going around the world to countries like India and South Africa, encouraging heads of state to invest in UHC, primary health care focus. And I think we should be very much supporting this work that Dr. Tedros is doing, talking to heads of state. So, concluding thoughts, I think that what we're recognising is that UHC is a highly political process, especially this issue of moving to an equitable, publicly financed system. You watch the United States elections next year in 2020, when there's a very high likelihood that a Democrat is going to be taking on President Trump, and most likely on a UHC ticket. So watch this space and you'll see what I mean. What we're recognising is that UHC is popular with people and politicians across the world. And it brings politics into health systems. I think this is something to be grasped and welcomed. I think in the days that when we were just pushing health systems as an agenda, politicians were tending to find this rather boring, dare I say. But the idea that we're covering everyone, we're protecting everyone, intuitively politicians like it, so we should grasp this. Now, within the debate about UHC and what do you scale up next, cancer is undoubtedly a highly emotive and therefore political issue. So use it wisely, I would suggest. And I think, therefore, that ensuring the UHC reforms include cancer control services. Of course, it will require using the technical arguments and getting all the evidence right. But also, I think we need to be thinking political strategies right from the outset. And combining the two, we're going to be much likely to be successful. Thank you very much indeed. Thank you.
Robert, thank you very much indeed.